Okay, good evening, everyone, and thank you for joining us this evening for our panel conversation with a group of our very esteemed Ramaz alumni pediatricians entitled Taking Care of Our Children, COVID vaccine, and all of the information that people would like to know, everything you've wanted to know about the vaccine. And hopefully weren't afraid to ask, because I think many of you have asked, but really bringing it all together into one conversation. And this evening, we are very, very honored to have with us three very, very well-known people in the area of pediatrics generally, and in specifically have an expertise with the vaccine and will be able to share a lot of wonderful knowledge with you. I'm going to introduce the panelists and then get right into the evening. We again thank all of you for joining us and remind you that many of you already did send in questions prior to this evening's conversation. However, there is also the opportunity to use the Q&A button at the bottom of your screen to additionally put in questions, and we will be happy to address as many of them as we're able to get to before the end of the panel conversation. I begin with introducing Dr. Sharon Nachman, class of 76. She is a professor of pediatrics and the chief of the Division of Pediatric Infectious Disease at Stony Brook Children's Hospital. She is also the vice dean for research at the Renaissance School of Medicine at Stony Brook, and she directs the Office of Clinical Trials at the institution. She is a renowned scientist and clinical investigator with more than 25 years of continuous NIH support. She has over 175 published manuscripts in peer-reviewed journals. And most notably for this evening, her clinical trial site at Stony Brook is one of the only 2 New York State sites for pediatric COVID vaccine studies and COVID monoclonal antibody studies in children. For us, she is quite famous because she is the proud mother-in-law of Tamar Benes, an esteemed Ramaz alumna and also a master teacher in our high school today. Rebecca Zausmer Sendowitz, class of 95. Rebecca graduated from Barnard and Albert Einstein's College of Medicine. She completed her residency in general pediatrics at Cohen's Children's Medical Center. And then for the past 11 years, she has worked as a pediatrician at Turow and Tierney Pediatrics in Great Neck. I'm sorry, Rebecca, in Great Neck, Long Island, where she has become a very, very well-known pediatrician and sought after by many, many of our own Ramaz families. She is the proud mom of 4 children, aged 6 to 16, the oldest of whom, Sam, is a current junior at Ramaz. And then our very own Jason Perlman, who many of you have seen on our Zooms before. Jason Perlman is a graduate after Ramaz of the University of Michigan, and then went to Israel to the Sackler Medical School. He did his pediatric residency at Beth Israel and Long Island College Hospital, and he is a primary pediatric infectious disease specialist for over a decade. He also has opened a practice, and in the past few years is a general pediatrician and an infectious disease consultant in Brooklyn. He has been an infectious disease consultant for Ramaz over these past many years as well. And he lives with his wife and a son in Brooklyn, New York. And we thank you once again, Jason, as well, for being with us. So you hear that we have an amazing panel this evening. And to start us off and to give us an overview of the topic, we ask Dr. Nachman to begin the evening. Thank you all for being on with us. And again, there's a Q&A at the bottom of the screen. Please use it, and we will try and get to as many questions as possible.
Good afternoon or evening. It's nice to see everybody. And thank you for that lovely introduction. Tonight, we're going to talk about COVID vaccine facts and myths. So what we're going to cover is a bit about the virus and the vaccine, some myths, some truths, and a bit of question and answer. I have no conflict of interest. I don't get paid for any talks, and I am fully funded by NIAID, NICHD, and NIMH, and I'm the PI of a maternal child network called Impact. Well, this is an RNA virus. An RNA virus is a very long, complicated family structure. They're single-stranded negative and positive sense. They're enveloped and non-enveloped. And as you can see by the blue line pointing to where SARS-CoV came by, that gives you the genealogy of our virus. So that means if you've seen some viruses that are close to this virus, maybe you'll have some antibody, but any virus that's a step or two away from where we're sitting right now with SARS-CoV-2 on the bottom of the screen has no antibody protection for what we have right now. So how do we get the vaccine, the virus into us, and how do we develop immunity? And this is a very interesting slide that talks about that. First, we have the coronavirus with its little spikes sitting around the central core. The spike protein, which all familiar with, the M protein, which is a little bit smaller, and the inside are the RNA message that tells it what to do. The spike protein attaches to an ACE2 receptor on a cell. If the cell does not have an ACE2 receptor, it's not going to attach. And that's key when we start thinking about some of the myths as to whether the virus or vaccine will alter our cells. If there's no ACE2 receptor, the virus does not enter the cell. Once the virus enters the cell, it opens up. And when it opens up, the RNA inside it gets read by your cell, and your cell says, okay, let's read it. Let's make some proteins. It reassembles into a new virus, lots of copies, and that virus then kills the cell on the way out the door. So every time a virus touches a cell and enters it, boom, that cell is gone. Now your body says, oh my God, what are those little viruses floating around? We don't like it. It sees a spike protein on the surface of the cell, and it says, wait, this is stuff we don't like. We shouldn't have it here. Let's start to have some T helper cells and make some antibody. And at the end of the day, you make lots and lots of antibody. It attaches to any new virus floating around and prevents that virus from entering the cell. So you have some short-lived cells that make antibody, and you have some long-lived memory cells that say a couple of months later, when some new virus that looks exactly the same, it's got that same spike protein on its surface, it says, hey, wait a second, we saw this garbage many moons ago. Let's make antibody, and let's have that antibody come by and protect us. What is not known about coronavirus is how long those memory cells will be sitting there and patrolling the body, and how long will they continue to make antibody. So the mutation that attaches to your cell, that spike protein, in the original virus only had one finger open. That meant that the virus needed to use its own energy to be more infectious. Over time, 2 of those fingers opened, and then now with the Delta strain, all 3 fingers are open. What does that mean? That means the virus doesn't need to use its own energy to attach to its cell. It's in the open and ready position to attach to any cell that's got that ACE2 receptor. That means it is much more infectious. The same sneeze that passed virus with the original strain was somewhat infectious. Now with that same sneeze passing virus, it is almost all infectious virus that gets passed from one person to the other. When we look across time and we say, well, what strain are we seeing now? You can see on the slide on the left that from a very short period of time, the orange or Delta strain, which was just a little bit of virus that was circulating, became the absolute dominant strain. Because it was so infectious, it was so easy to spread. And when it's so easy to spread from person to person, it becomes more evident and more spreading. So where are we today? Well, now we've got that new virus variant circulating that everyone's heard, omnicron. And omnicron is a little bit of a different virus compared to the alpha, the beta, the gamma, and the delta, which are those strains that you see on the bottom of the screen in blue and green. The delta strain is the infectious one of all of those that are on the bottom. On this red slide, you can see that omnicron is quite different than the delta strain. It did not arise from delta being more mutated, but rather arose from the original strain that in and of itself became more infectious. To date, we don't have enough information on omnicron to say, is the antibody that we're producing from the vaccine going to be okay or not okay? And in fact, the current data from South Africa does not suggest that omnicron is more deadly, but rather it is as infectious or perhaps more infectious than the Delta strain. Remember, viruses need to succeed and survive as well. And if they kill off the host quickly, they themselves die out. They don't want to die out. So the best way for them to survive is to be highly infectious, but in fact, not kill the host. That's why we have so many rhinoviruses now. They pass from person to person super easily, but really don't do huge damage to the host. So you have your cold, you go to work, you go to school, you go on the subway, and you easily pass rhinovirus from person to person. And that's what coronavirus is doing now. It's mutating, so it is much more infectious, but none of the mutations that we're seeing are in fact so much more significant or more deadly. So as of November of 21, 6.6 million total children cases of COVID were reported. That represents anywhere between 16.8 to 17% of all cases. 2 weeks ago, there were 122,000 new cases with an overall rate of 8,000 cases per 100,000 children in the population. What's worrisome is that if you look at the data from this week, in fact, those numbers are increasing. So children, in fact, are becoming more of a population that's getting infected than in the past. More than 8,600 children have been hospitalized, with 1 in 3 hospitalizations requiring intensive care. That's quite bad for us because that means of the kids that are coming in now that are hospitalized, we can expect a significant hit on our pediatric ICUs if the same strains are around. Over 143 children have died to date. And for that multi-system inflammatory illness, we've seen over 5,000 cases with an associated 48 deaths. When we've looked at all of these cases, both the MIS-C as well as the children with COVID, the idea that most of them were kids that were immune compromised and had other medical issues is not true. Only about a third of those children who are hospitalized, in fact, had some underlying comorbidities. 2/3 of them were regular children just running around. The data from November 17th, looking at cases overall and which age groups were associated with those cases, is also worrisome because the percentage of cases in the little kids, the 5 to 11-year-olds, seems to be creeping up, and they represent more of the kids who are in fact infectious now. So basically, kids are in fact getting COVID, and they're also getting ill from it. But who's giving COVID to who? A paper from Science published in 2021 looked at the contribution to SARS-CoV infections as the share in the population. It doesn't take a statistician to recognize that 20 to 40-year-olds were the biggest contributor of new infections. However, the 10 to 19-year-olds, in fact, did contribute a fairly significant amount of new infections. So this idea that the parents are only giving it to the kids is not true. In fact, it means that kids are now giving it to their parents. School reopening has really not resulted in substantial increases in COVID attributable deaths from a paper in 2020, and this data has been looked at currently, and it seems to be about the same. Of those patients who died, only 2.7% of the infections originated from kids 0 to 9 years of age, but 7% of them originated from teens 10 to 19, meaning if we don't vaccinate our teenagers, they will bring COVID home and they will significantly contribute to deaths in those households. So in summary, there's lots of COVID infections out there. Kids are getting sick, they're getting hospitalized, they're passing it to the adults and kids in their households, and they're leading to deaths among those populations. So now let's turn for a minute and talk about vaccines. So what is this whole thing about vaccine and warp speed, and what did it really mean? Well, I can tell you exactly what it meant as someone who gets NIH dollars. It means we stopped working on anything else we were doing, and 100% of our effort, maybe 200% of our effort, went towards COVID, either in the lab or in clinical research. We basically didn't do anything else once COVID hit. In addition, anytime there was a clinical trial, either for a phase 1 vaccine or phase 2, or even the phase 3 vaccines, and we'll go into what that means in a minute, there were lots of volunteers. In the past, when we did clinical trials and we had a new vaccine, be it a Prevnar 13 or a Prevnar 20 or anything like that, we'd have to sort of stand on street corners and say, please, please, does anybody want to volunteer for this study? Do you want your kids to volunteer? And we could stand there for days, weeks, and even months and get no volunteers. With the COVID vaccine studies, we didn't have to stand on street corners. We actually had to hide in our office because hundreds of people were calling and emailing around the country saying, please put me in a clinical trial. I want to participate in clinical research. So we had lots and lots of volunteers. And in a clinical trial of 30 or 40,000 that in the past would have taken maybe 2 to 3 to even 5 years, enrolled in a month. In addition, in a clinical trial, in order to see if a vaccine versus placebo works, you have to be sure there was enough of that disease around. If it was a disease that we didn't see that often, your trial would have to be open for 3, 4, even 5 years. Unfortunately for us, there was a huge amount of COVID around all the time when these studies were enrolling. So we could see exactly how well the vaccine performed compared to the placebo, because we could count all those deaths and all those hospitalizations and all the patients that got sick because COVID was in their homes, in their environment all the time. So Warp Speed worked because of you. It worked because people stood up and said, put me on the study. It worked because we had a vaccine that we could pull into clinical research, and it worked because we could count events and they happened quickly. Clinical trials come in phases. The phase 1 is that we have something that we think looks good. We want to see if it's safe. Phase 2 is we want to see not only is it safe, but kind of what's the right dose. And phase 3 is, aha, we think we have the right dose. We think we know how it works. And now let's see, does it really work when you compare it to placebo? All of those were done sequentially and correctly. In addition, before you could ever put anything into a human, you had to put it into a non-human primate, as well as multiple other animal models, because the FDA won't let the first human take anything, be it an antibiotic, a vaccine, or anything other medication-wise, until we've had at least 2 animal models that showed that it can be done in humans. Because we know from medicine that if something works in an adult, it's going to also work in a kid. We may not know the right dose, but we can check that easily. We were not needed to prove efficacy or that the vaccine worked in children. It was more than enough for us to prove we had the dose and we could look at any kind of immune response from the kids who got the vaccine. Yes, we would collect safety data, but to look at something that has an event rate of 1 in 100,000, we're not going to do a trial of 200 or 300,000 because we have to balance the risks and benefits of moving the vaccine out versus what that adverse event rate is, especially if it's a rare or uncommon one. So therefore, in summary, the clinical trials were done sequentially, correctly, starting from the preclinical work in animals to the phase 1, 2, and 3 in humans, and then age de-escalated into a child as they were supposed to do. So what were the vaccines out there? Well, there was a protein-based vaccine, a viral vector vaccine, and that favorite of ours, the messenger RNA vaccine. The protein-based vaccine means you ripped off a piece of that spike protein, you purified it, and you injected it into humans and see, did you make an immune response? The protein-based vaccines were quite a bit behind all of the other vaccines because they required more time to grow the spike protein, to purify it, and then to attach it to something we could vaccinate you with. The viral vector vaccines were a little bit easier. They took that spike protein gene. We didn't have to grow any spike protein. They attached it easily to an adenovirus, which is a virus that easily gets into cells, but that adenovirus had any of its growth properties knocked out. So that virus, a stupid general adenovirus, with a little bit of spike protein antigen gene in it, then moved into your cells. Your cells opened up the adenovirus, said, oh, sure, we'll read that message. You made a spike protein. The cell threw the spike protein out, and again, you made antibody. The last of these was much more elegant. The messenger RNA vaccines took the message that was for spike protein, it purified it, and put it in a nanoparticle. That nanoparticle sneaks right into your cells. It doesn't necessarily need the exact same ACE2 receptor or anything like that. It's much easier to sneak in. Your body reads the message, produces the spike protein, throws the protein out of your cell, and again, you make antibody. What's lovely about the messenger RNA vaccines is once it reads the message, it rips it up. Think of yourself when you were in grade school, you passed the message to your neighbor and said, eat that message or rip it up. That's exactly what your cell does. So in fact, once the vaccine nanoparticle has entered your cell, 6 hours later, it's destroyed. It never enters the DNA of your cell. It cannot change your cells. It's not long-lived. All it's doing is carrying that message in, and your body reads messages from cells all the time. So everybody took a piece of that spike protein message down that you see here in brown. Either they put it into a nanoparticle or put it into an adenovirus like the J&J and the AstraZeneca vaccines did. The third choice of that protein vaccine is a company called, now I'm forgetting, who is actually not licensed right now, Novavax, who's not licensed now in the US. So still unanswered for us is the primary series for kids, a booster, not a booster, what are we doing next? And we can talk about that in the Q&A. What about timing? Well, it's interesting is we don't really know. What we do know in pediatrics is that kids are always getting primary series of vaccines and then months to a year later getting a booster. And we know from other pediatric vaccines that that time frame between a primary series and the booster really is quite helpful. Getting it too soon, probably not so good. Getting it later, even a bit later, is certainly wonderful. We've also learned quite a bit over the past few months about mixing and matching. And the short answer to that is absolutely we can. We also know for that from pediatrics. When your children are getting their 2, 4, and 6-month vaccines, thinking they're always getting it from the same company all the time, they're not. What you're getting in your pediatrician's office is the DTaP, Hib, IPV vaccine, but it can be made by multiple manufacturers. They are all effective. And in fact, when you get one from one company and swapped out from one from a different company, you see no difference. Your child sees no difference, and their immune system goes, oh, that's fine. So based on that information, as well as the in-people information about swapping, we know it's quite fine to mix and match the primary series, the first 2 doses that you're getting, with a booster from another manufacturer. So I thought I would spend a little bit of time looking at the dosing and the volume of patients that got that dose from the clinical trials. In the column under Pfizer, you see that the 12 to 16 and the 16 to adults got 30 micrograms, the 5 to 12s got 10, and the little kids under 5 are getting 3 micrograms. Please don't compare it to the dose in Moderna, where the 12 to 17 and adults got 100 micrograms, the 6 to 12-year-olds are getting 50, and the under 6s are getting 25. While they are both fruit, meaning they're both COVID vaccines, one is an apple and one is an orange. They can't be equivalent, and you shouldn't say, oh no, I want the vaccine that gives my little kid 3 micrograms, not 25 micrograms. One does not compare to the other. However, let's look at the adverse events now, and this is a table from the Pfizer vaccine. And from right to left, you can see the older adults. Don't get scared, those are 55 and older for Pfizer. I never knew 55 was older. Younger kids or younger adults are 16 to 55, and the kids here are 5 to 12. It's easy to recognize that the older adults, in fact, had less of reactogenicity compared to the younger adults, those 16 to 55. But in fact, the kids did quite well and had less reactions not only for dose 1, but as well for dose 2. Is it because they got a lower dose? Is it because they're used to vaccines and don't complain about headache, fatigue, and muscle pain like us adults do? Or is it a combination of the two? And the answer is I don't know, but it's nice to see that when parents ask kids every single day as part of the clinical trial, how do you feel, what's going on? They actually, after 24 hours, were pretty much all back to normal, fine, and back in school. That's somewhat different from our adults that may have complained for a day or two longer, but in fact, even amongst the adults who were on the study, by 48 to 72 hours, they were also back to normal. So let's spend a few minutes talking about the myths and the half-truths. The first and my favorite myth is vaccination interferes with fertility. The short answer is, of course, that's not true. The vaccines were tested in 2 different animal models to look for fertility and pregnancy signals. Okay, you don't want to believe the animal model data? Okay, let's go with the human model data. So over 35,000 women identified as pregnant received COVID vaccines. Their data was reported in New England Journal. And in fact, they had no changes or increase or issues with fertility. There were no neonatal deaths. The preterm birth rate was the same in those who had gotten vaccine as the pre-COVID population. And in fact, their pregnancies and all of the adverse events associated with pregnancy were no different in those who had gotten vaccine versus those who had not gotten vaccine in the pre-COVID population. There's a group called the V-Safe reporting group, and they have currently over 120,000 pregnant women reported in their registry. They're all continue to be followed. And in fact, they too have no issue with their pregnancy, labor and delivery, or outcomes of their babies. What about the side effects for these women? Well, Pfizer reported on about 9,000 women. Moderna reported about 7,000 women who were vaccinated. Again, you don't need to be a statistician to see there's actually no difference between pregnant and non-pregnant women across every single pain, fatigue, headache, myalgia, dose 1, or even dose 2. No difference at all on these graphs. Well, what are some of the other fertility myths? The vaccine or the antibody is going to attach to the ovary. Okay, that's not true. The ovary doesn't have an ACE2 receptor. Also, any similarity between a short sequence of antibody to spike protein and any kind of receptor on the ovary is like trying to recreate the Bible using only 6 letters. You can't read it, I can't read it, and it makes no sense. So thinking that the vaccine will attach to the ovary is not true. And thinking that antibody that you make from the vaccine will also attach to the ovary is also not true. Well, vaccine or antibody attaches to the placenta. This is my favorite myth. Why is that? Because it tells me that you never remember your 10th grade biology. The placenta is made by the fetus, not the mother. So it means it actually is not an issue with fertility. You're already pregnant. No vaccine ever crosses the placenta because it's a wall. That's why a mom who is B negative can have a baby that's AB positive without knocking off the fetus. That placenta wall is very effective. An antibody does not cross until 36 weeks because at 36 weeks, the placenta does open, but only for antibody. So if you have no antibody at 36 weeks, your baby will get no protection. This was developed exactly so that when babies are born into the world and they see lots of viruses, anything the mother saw will also help protect the baby. There is some antibody in breast milk, perhaps some, but certainly not enough past 6 months of life. So there's no receptor on the placenta that matches any antibody made to vaccine. Well, what about male fertility? Well, we do know that COVID alters sperm. In a study done in men who were in their 30s, who in fact did have COVID, there was male subfertility in all. There were in fact worse outcomes associated with severity of disease, meaning that at 3 months, those who had mild disease had their fertility restored. Those who had more severe disease were not restored until after 6 to 9 months. COVID vaccination itself does not alter male fertility. They had a study of sperm parameters before and after 2 doses of messenger RNA vaccine and found no decreases in any sperm parameter among the cohort of healthy adult males. So if you're going to have a choice between COVID and the vaccine, the COVID will certainly hit the fertility while the vaccine won't. What about the myocarditis? And I think this is important to take a step back and say, let's not get stuck in the words. Myocarditis means inflammation of the heart muscle. That inflammation was reported from the cases reported to the Vaccine Adverse Event Reporting System from the CDC, or the VAERS system. Each one of those cases were investigated. What did they find? Well, it was more often in males versus females. It included a group of 16 to 30-year-olds. And more importantly, these cases were mild. They are quite different than the myocarditis that we see with viruses. These cases of myocarditis were often sent home from the ED or the office, rarely admitted, and their treatment was Motrin. So was it the dose of the child, the age of the child? We're not necessarily sure why that inflammation occurred, but more importantly, it was transient, meaning short-lived, easy to identify, easy to diagnose, and more importantly, easy to treat with Motrin. Well, the myocarditis pre-COVID related to viruses had an event rate of 1 in 100,000. The COVID-related myocarditis in that same age group is 150 events per 100,000. So you have to think about, is it the COVID causing the myocarditis or the vaccine? Obviously, you'd rather get vaccine-associated myocarditis than COVID-related myocarditis. Well, are there any other vaccines that cause myocarditis? And it gets back to how well we studied those mild cases. These are kids who had shortness of breath, maybe some chest pain. It was incredibly transient. So unless you caught it, you missed it. There was a myocarditis report associated with smallpox vaccine, which had between 12 and 400 cases per 100,000 patients vaccinated. It was subclinical and really found due to increased surveillance. So that myocarditis, also an inflammatory response after vaccination, was transient, improved, and no treatment for these patients at all. So when people think about myocarditis from vaccine, which has an event rate of about 3 to 4 per 100,000, compared to the myocarditis event rate from virus, obviously the virus myocarditis is even worse. So as of November 10th, 2021, the VAERS system had received over 1,700 reports of myocarditis or pericarditis among people 12 to 29 years of age who had gotten vaccines. In that same population, there were 442 million doses given. So you can again see that there were some cases of myocarditis, but they were insignificantly numbered compared to the amount of vaccine that we administered. The Kaiser report, the group reported 5.8 cases of myocarditis per million doses administered. They were all male. They were 20 to 32 years, and that's about 0.6 cases per 100,000. For the Israeli data set, there was 5 million Israelis 16 and older who were at least partially vaccinated with the Pfizer vaccine. There were 142 cases linked to vaccine, which rounds out to about 3 cases per 100,000 doses. So yes, we are seeing some myocarditis from vaccine, but that myocarditis or inflammation of the heart is like saying the arm that I broke just falling on the basketball field and okay, I had to get a cast 6 weeks later, I was better, is the same broken arm that I sustained after being hit by a car and my arm was separated out into like 10 million pieces. They are not the same. Yes, they're both broken arms. One in 6 weeks is better. The other one is going to take multiple surgeries and multiple months until you can use it again. This is a table from the CDC that looks at million doses administered for each group, the risks and the benefits by male and by female. We're not going to spend a lot of time on this because this is available to you, but you can see for every million doses given, we are preventing in men 12 to 29, 11,000 cases of COVID, 560 hospitalizations, 138 ICU admissions, and 6 deaths. So obviously the numbers, especially now when we're thinking about Delta, as well as any of the new variants coming through, mean that we really need to prevent these cases. So there's a JAMA paper also looking at athletes post-COVID, because you may say, well, those kids weren't so healthy or those adults weren't so healthy. And if they got their COVID when they were healthy, they'd be fine. So this JAMA paper looked at athletes who had COVID. It used cardiac MRI to look for heart issues. It included 26 athletes from Ohio State University, 4 of the 26 had cardiac MRIs that were already consistent with myocarditis, and 2 of them had only the mildest shortness of breath. Everybody else said they were fine, but in fact, when they saw the myocarditis, those kids were pulled out of sports and basically are not going to be allowed to play their sports for the rest of their college career. So thinking that if you're totally healthy, you'll have some myocarditis and you'll be fine is of course not true. And this is the vaccine adverse event reporting system. And the reason I put it up is because anyone can report on the VAERS system. You don't have to be a health provider or anything. As long as you have some of the information and put it in, the CDC will track you down. So what are the next steps for us to do? Well, we'd like to vaccinate kids 5 to 12 years of age. The data was presented to the FDA and then to the ACIP, the Advisory Council on Immunization Practices. To date, over 1 million doses has been given to this age group across the US. Right now, there are no reports of myocarditis, but I'm sure we will start seeing a few. What is the incident rate of that population? We don't know. Is it dose-related or age-related? Also questions that we don't have, because the rate of myocarditis in the under 12-year-olds is much lower than the over 12-year-old population. So I'm sure we're going to see some. The question is, how serious will it be? And how will those kids do? When will we be able to vaccinate kids under 5 years of age? Taking out my very cloudy crystal ball, I am hoping that in January, February, Pfizer and Moderna will report their data to the FDA. And then we'll see how quickly ACIP looks at the data and says, okay, it's good to vaccinate those kids too. What about boosters in kids? And that's something I think the panel will discuss. What about kids with underlying medical issues? Well, many of those kids were not enrolled in the study because people were worried that if I put my kid on a clinical trial and they have a problem, what to do? Now we're stuck. So if your child has underlying medical conditions, you need to talk to your child's medical provider. They do need to get vaccinated, and we need to understand how they're doing and what's going on with them, because there may be other alternatives. If they can't get a vaccine, maybe they need a monoclonal as preventative. Well, if your kid is in school and they're on a sports team, you need to think about who else are they playing with, because we really need to think about their entire community as who is sharing virus one with the other. So we need to think about getting back to the office safely. We need to think about deltas, not the jet. It's interesting that delta is not referred to the delta strain by its name of delta. And we need to think about flu vaccine and COVID vaccines. What's the best timing? And as a pediatrician, I can tell you, if you have the kid in your office, give them their shots. So there's no downside to giving flu vaccine and COVID vaccine at the same time. Who knows what the next few months of 2021 and 2022 will bring, but I can imagine we will be talking about the change in the variant, whether the vaccine will be useful for it as well. Be careful where you read information, talk to your child's health professional, and above all, remember, we are all part of the same community. So I'm going to stop there and hand it back to you, Ken.
Wow. Thank you, Dr. Nachman. I think we're just really catching our breath from all the information that you just gave over to us in such a clear and a way that we could each digest. Although this is very difficult information, I think that it is amazing how easily you imparted it to us. And I know that many of the people who came forward with questions before have already had their questions answered. However, there are a series of questions that I'll pose in any event to the group, and we'll see if we can answer some of the additional questions. And as I said, we do have the Q&A at the bottom, and we'll get to some of those questions perhaps as well. So to give you a break, Dr. Nachman, I'm going to ask Dr. Perlman to begin with. Dr. Perlman, will the COVID vaccine be a routine childhood vaccine or an annual vaccine like influenza?
We don't know. It depends on if the virus continues to mutate regularly, or if it becomes a stable viral genome. If that's the case, then it could be a routine series based on follow-up studies of antibodies in children. If it's an annually mutating that virus, then it would be probably more in the realm of a flu-like situation.
Okay, thank you. I'm going to go to you, Dr. Zausmer, if that's okay. Will kids age 12 and up need boosters? And if so, when do you think they will be approved in the US, if you have any information on that?
I do not have any information on that, when they'll be approved. I think it's a good possibility that kids will need boosters. I think, once again, we have no way of knowing at this point. In the adult population, the need for boosters was really shown 6 months after they received their second vaccines. Most kids, even the kids age 16 and up, who were the first ones to get it, have really just passed the 7-month mark. The younger kids in the 12 and up group are approaching the 6-month mark. So I think we're going to see a little bit in real time if we start seeing infections in those kids. And then I think we'll see. And I don't know if that will be approved. In Israel, it is actually approved to get boosters in age 12 and up. I don't know if Dr. Nachman, who's been working on these trials, has more information on that.
So there's been a lot of talk about boosters for the younger children. And the issue is that the younger children are very immune competent. They're really much smarter immunologically than even the 18 and 20-year-olds. So while I do agree that there will be a booster, I think it may be even a bit longer than 6 months. And that's good, because we're just bringing those 5 to 12-year-olds in now. We have the time to actually look at when is the best time to give them their boosters.
Thank you. Dr. Perlman, how can such a rapidly developed vaccine with new technology be trusted? I know we just listened to Dr. Nachman speaking about this for a while, but could you answer that in the way that you've seen it over your practice?
Well, I'm going to just rephrase a lot. To my understanding, mRNA technology has been around since the AIDS epidemic, and the approach to trying to develop a vaccine against that virus, and has subsequently been processed through the vaccine chain. But this is a very known technology, and as Dr. Nachman said, once it's read, it disintegrates, and never before, at least as far as I could find, has such post-phase studies had the same reported outcomes and experience with the vaccine across such a global political, ethnic, racial differences, and we're all seeing similar, reporting similar effect and vaccine study and protection worldwide. So I think it's a really vetted vaccine. Just to be on a soapbox one sec, like the scientific method, as Dr. Nachman alluded to, is real. It's vetted. It's trusted. When we start calling into question science, we're taking a big step. And when you have so much vetted, reviewed, transparent data, I think it needs to be respected.
Thank you. Dr. Nachman, someone just asked, my child already had COVID. Do you really still think they need a vaccine?
So that question has been answered in a few different ways across the US. So the first is, there's data from Kentucky where they looked at the entire state. They didn't specifically look at children, but they looked at anyone who had COVID, and then looked at people who had vaccine. And then they said, who's getting round 2? And in fact, your risk benefit or likelihood of getting COVID round 2 was several times higher if you only had COVID the first time as compared if you had just the vaccine. So it is our belief that if you've had COVID round 1, you're actually at a higher risk for getting COVID round 2 than if you get a vaccine. Having said that, do we need booster series for those kids or adults who had COVID and they get vaccination? I don't think we have the answer to that. But certainly if your child or an adult has had COVID, I would still go ahead and vaccinate them because the data suggests quite strongly that you can decrease their risk if they've been vaccinated.
Thank you. Dr. Zausmer, in your practice, have you seen breakthrough infections in vaccinated kids? And is it more or less common than in adults, if you know that as well?
In our practice, and we have estimated in our practice that around 70% of our patients aged 12 and up have gotten the vaccine, which does correlate with the rates on Long Island and in Queens where we are. We have seen exactly one breakthrough vaccine infection in all of those kids. And that was a child who did receive the vaccine, the second shot in June of last year. So it is about 6 months, but it is very, very few and far between. The vast majority of children who have gotten vaccinated are not getting reinfected with COVID to this point. Obviously, as time goes on, we will see how things go. And it is obviously very, very clear that the majority of kids who are getting COVID are the children who are unvaccinated. So basically today we had in our office 4 cases of COVID and none of those children were vaccinated. Those children have probably 10 siblings amongst all of them, and they are all now at high risk of getting COVID. And because we see that people within families tend to vaccinate, many of those children's siblings are unvaccinated and are probably going to be getting COVID in the next few days. So clearly, being unvaccinated is a much higher risk of having COVID than having had 2 vaccines and getting it.
Thank you. A question that came in this evening, and Dr. Perlman, I'll ask you if you would. Should you check if your child has natural immunity before vaccinating them?
I'm not familiar with that approach. Dr. Nachman is going to answer this one.
So I'm going to take that one. And so the answer is twofold, 2 different types of answers. The first is antibody, which you can test in the lab, doesn't necessarily correlate with antibody that can protect you from infection. So thinking that you have a high titer of antibody doesn't necessarily mean, oh, you're supercharged and won't get infected. When we do a study, we don't just look at antibody, we look at functional antibody. And none of the general tests that are available now in the public look at functional antibody when they're testing for antibody. So we don't want anyone to test. The second is we don't know what's the level of protection or how quickly that level will wane. So if you've had COVID in the past, it could be on month 1, you have great antibody coverage, but month 2, somewhat less, and then month 3 is a sudden drop. So unless you're thinking that you're going to be blood testing your child every single month and know upfront what's the level of protection, and that's when you're going to swoop in and vaccinate them, it's not a good plan to start looking for natural immunity or natural antibody production. You're a much safer place to say, I'm not going to worry about this. I'm actually going to vaccinate you so I know you're protected.
Thank you. We had, Dr. Nachman, several people who asked, and this sounds like a question that you can answer for us, that if my children had a lot of allergies, can they get the vaccine?
So there's actually a huge database from the adolescent and adult populations that have been vaccinated. In general, adults have pretty much the same allergies that kids do, maybe a tweak more or a tweak less, but by the time you're an adult, you have even more allergies than you did as a child. And looking at all of those reported allergies across the entire spectrum, from food to antibiotics to plastic to you name it, not a single one of those, except an allergy to a single component of the vaccine, has been a contraindication. And those kids who have that single component vaccine also can't take Miralax, which is something we give kids all the time for constipation. So if you have a child that is allergic to Miralax, they are in fact are the only child that can't get a vaccine. But if you're allergic to an antibiotic or some other food, there's no problem. Why do we know that's true? Because these vaccines are held at -70 degrees. The reason they're held at -70 degrees is they have no preservatives and no antibiotics in them. They're very, very, gentle with the vaccines. Once you defrost it, you have to use it because it doesn't have a shelf life. Because it has no preservatives and no antibiotics, those things that kids are routinely allergic to are in fact not part of the vaccine. So you can go ahead and use it in your children.
Thank you. I pose this as an open question that's very advantageous for Ramaz to have on this evening's panel conversation, because it's being asked very often. Once fully vaccinated, can my child stop wearing a mask?
The answer is
Who would
maybe.
like-
The answer is yes, no, maybe. There's no one right answer. And I think right now, until we have enough of a population totally vaccinated, it's going to be hard to say, you don't wear a mask, you wear a mask, you don't, you do. I think that's going to be a huge stigma issue, but more importantly, we don't know who will bring some asymptomatic COVID home and pass it to grandma or aunt and uncle who lives in the house or who's visiting with them on Shabbat. So I think right now, discretion is always more important. And I think keeping the masks on until we see how the pandemic is changing, particularly with the new variants, is a much smarter approach.
Thank you. Dr. Perlman, this was an interesting one. Maybe you probably can talk about this. Why are there discordant PCR results within a household?
That's a very good question. I don't think that I'm sure that's not clear yet. All I can offer from my past is that there's a whole battery of research that is trying to understand why some people respond to Agent X in one way and some people respond in another way, and who's more predisposed to being colonized with something versus someone else, such as staph or MRSA. The host part of it is not well elucidated, let alone the limitations of a new virus.
Okay, thank you. Dr. Zausmer, since you have a child in Ramaz, I'm going to ask you to take this one. And I knew that it was going to come up because you probably get asked it all the time in your practices. Did you vaccinate your own children?
Yes.
Sorry if it's too personal.
No, it's okay. I vaccinated all of my own children. Even most recently, as you mentioned, I have a 6-year-old. We took her basically the first day. She got her second vaccine yesterday, and she's totally fine. Celebrated Hanukkah last night, had a great time, bopped off to school this morning. I think it's very, very important to vaccinate our kids because that's what's going to let them get back to their real lives, which is what they obviously want. It's what's best for, it's what's best for them, that they are involved in all their education and their activities. And as a parent, that's what makes you feel that they can do that safely. We want our kids to be safe and we want them to be happy and out there and active. And so from my youngest to my oldest, actually, I think my oldest also went on the first possible day. As soon as we could, we took them and they were all vaccinated. And thank God they're all doing, out there doing all the things that they want to be doing now, which is great.
That's great. And thank you for giving us that personal insight. Dr. Nachman, this was an interesting one. What happens if a child ages up between vaccines? They're right in between. Do you use the lower or the higher dose of the vaccine?
So the answer is both yes or fine. The FDA, in fact, did get posed that question by one of the community groups. And their answer was, you can give the age-appropriate dose, meaning the larger dose or larger dose for the over 12-year-olds, or you can certainly give them the lower dose for the under 12-year-olds. And you won't be dinged for it, you won't get any adverse event reporting, and you won't be called up in public or anything like that. And why is that? Because immunologically, 11 and 3/4-year-olds and a 12 and 2-day-old are actually the same. And there's no problem giving them the lower dose, and there's no problem giving them the higher dose. So I think it really means go ahead and get your vaccine and don't count, did you get the higher dose or the lower dose? Both are going to be equally effective in that age group. And you won't have to get an extra dose if you got the lower dose. No one's going to chase you and say, wait, you have to get a little bit more into you.
Okay, I guess there's a question that came in on this evening's questions. Will the vaccine most likely protect my child from the new variant, and how dangerous is this variant? You referred to it slightly, Dr. Nachman. Could you talk about it for another couple of moments, please?
Certainly. We had a nice call this morning with our colleagues in South Africa to ask for those patients that are in the ICU, were all of them the new variant? Were they the Delta variant? And in fact, were one group sicker than the other? So what they answered, interestingly, is that the new variant seems to be taking over Delta. They're not seeing as much Delta. They are seeing the new variant, but the patients are not sicker. They are not more in the ICU. They're not more coming into the hospital. They're just being replaced. So the question right now is people are not sure if the new variant is in fact going to be more dangerous, but it certainly does look like it may be a bit more infectious. Is it because the South African population is living closer together, has underlying immune issues or some other issues going on that they may be somewhat different than the US population? We don't know. With regard to the antibody production from vaccine, those studies are actually ongoing right now. So I don't have an answer as how well the match will be from the antibody you make from vaccine to the new variant. But certainly in the next few weeks, we would like to be able to answer it. But when you think about those people who had COVID with the alpha strain, and now we have the Delta and the new variant, omnicron, running around, in fact, you need to think about those people should definitely get vaccinated because we know that the vaccine easily covered the Delta strain. So if I had to put money on, quote, natural immunity from the original virus that circulated back in 2020 versus getting a vaccine now, I think you would be safer with the antibody you make from vaccine than from any antibody you had to the first infection that rolled through the US.
Okay, this has been amazingly informative, eye-opening, and very helpful. I know as a parent, I'm feeling it. I can already see from parents' comments and feelings that this has been very helpful. Dr. Perlman, Dr. Zausmer, Dr. Nachman, is there anything you'd like to add to anything that you've said this evening or that's been asked before we close the evening? Yes, Dr. Nachman.
So just one last comment that 10% of the children that were enrolled on the clinical trial, those kids who are 5 to 12, in fact, either had COVID at the time of vaccination or had COVID recent to the vaccine, and we didn't know it. But in fact, none of those children had increased adverse events, and none of those children had any untoward response to the vaccine, and all made a good immune response to the vaccine that we could check because we did blood before we gave them their first dose and blood again after dose 2. So even if you're worried that your kid had a recent COVID exposure, you don't know, did they have COVID, not have COVID, you can still go ahead and give them the vaccine. They will still get plenty of bang for the buck.
Dr. Zausmer, Dr. Perlman, anything you'd like to add?
First of all, I'd just like to thank Dr. Nachman for such a wonderful talk. And I would like to say that what we have seen in our clinical practices really reflects what she presented, which is always nice, that the vast majority of kids tolerate the vaccine very, very well. I think actually better than adults. I was expecting to get lots and lots of calls every day once we started giving it out. And I have to say, I've heard many more complaints from my peers and my friends about when after they got the vaccine. I really, very few parents have called to tell us their child has had a significant, not even an adverse event, but even a significant reaction. Sure, some kids have, but really much fewer than I thought was going to happen, which I think is great for everybody. We had no serious side effects where we worked, and that really reflects in somewhat real time, the data that Dr. Nachman presented, which I think is terrific, and I think that people can really be reassured by that. And thank you for having me.
Thank you.
Thanks for having me. Happy holidays. Yeah, Dr. Nachman is well known in the pediatric infectious disease community as a major contributor, not only on COVID vaccine, but on Gardasil and others. And it is always nice to present with her. The other thing, and just to even hit it home further, no one in the 5 to 11-year-old study, regardless of status, immune naive or immune having been infected, developed myocarditis or anaphylaxis, to my knowledge, either. So the safety just keeps being pounded in over and over. And herd immunity is actually, from this, being estimated to be at an 85% community vaccination rate, which is higher than the 70 that they were discussing a year ago. Clearly, it's a moving target. Vaccinate.
Wow. Okay. Well, I have to say, as a fellow graduate of Ramaz, I can't tell you how proud I am to have been part of this evening with Dr. Nachman, Dr. Perlman, and Dr. Zausmer, 3 outstanding physicians who are making a very, very big difference generally, but specifically at the time when we need people on the front lines who are doing God's work in the way that they are. So we thank you. We wish you continued health and strength to be able to accomplish all this. And you've brought a lot of light into our home this Hanukkah. We wish you and your families a Hanukkah Sameach, and to everyone listening as well, have a great night.
Thank you. Hanukkah Sameach.
Bye.
Thank you. Bye.